Hello, I'm Teresa Bird. I am one of the maternal co-chairs for GAP-UC, and we're here to talk about Heart Matters, Navigating Cardiovascular Disease in Pregnancy and Postpartum. I'm going to start with a case. We have a 25-year-old obese African-American G2P2 who presents to the ED 10 days after an uncomplicated vaginal delivery with fatigue and persistent cough since delivery. Blood pressure's normal at 110/80, heart rate 110, respiratory rate 28, afebrile with an O2 set of 94% on room air. She gets diagnosed with a respiratory infection and is prescribed an antibiotic. Fatigue is attributed to lack of sleep. One week later, she presents again with continued symptoms. Antibiotics are switched and beta agonists are added for presumptive new onset asthma. 2 days later, the patient experiences cardiac arrest at home and resuscitation attempts are unsuccessful. Unfortunately, this is a story that we've heard time and time again, and it's actually very similar. Autopsy findings here were indicative of cardiomyopathy, but this is a story that we've heard altogether too many times. And for many of us, we may know of patients and had an outcome similar to this, but this story is also similar to Dr. Shalon Irving, who was a CDC researcher here in Atlanta, who died a few days after giving birth with similar complaints and because of a similar presentation. So we're here today to talk about this. It is the leading cause of pregnancy-related deaths are cardiovascular conditions in Georgia, specifically according to the 2020-2022 data, and we can see that here. We also see that it was the leader of all pregnancy-related deaths from 2019 to 2021. Maternal mortality is on the rise. I think one thing of specific importance is to note the timing of the death. And if you look here, we concentrate a lot on pregnancy-related death that happens during pregnancy, but haven't focused on the postpartum period as much. And looking here, the majority of the deaths actually happen postpartum, clustered in the first probably 60 days postpartum, but there's still, look here, 28 deaths that happen between 60 days and a year postpartum. So really important that we focus on the postpartum period, which is something I want to highlight here as well. So question, what patients are at highest risk of cardiovascular events during pregnancy or postpartum? And those patients that are at highest risk of having an event are patients with WHO class 3 and 4 cardiac conditions. And so the pregnancy WHO risk class 3 patients have a significantly increased risk of maternal mortality or severe morbidity. They have a 20 to 27% maternal cardiac event rate. And these patients generally, when they are pregnant, should be followed up by cardiology Q1 to 2 months. And contrast that to WHO risk class 4 patients. Those patients really should not be pregnant, and pregnancy is contraindicated in those patients because the mortality rate is so high. So they have an extremely risk of maternal mortality and severe morbidity. They have a greater than 27% maternal cardiac event rate. These patients should have induced abortion discussed with them if they are pregnant. And I just want to pause here for a second to say that, we all know of the political environment that's going on right now and the abortion bans that exist throughout our country in different states. And regardless of whether or not you practice in an abortion restricted state, these patients with known WHO class 4 conditions should be counseled on the fact that pregnancy is contraindicated because their risk of death is so high. And you should recommend that the patient consider an elective abortion because of their severe risk. Patient may choose to go out of state to obtain these services. It is something that you should make sure that you talk to your patient about. If these patients remain pregnant, they should be followed by cardiology at the minimum of monthly. And these are some of those conditions. So WHO class 3 and 4 conditions: mechanical valve. So the class 4 conditions are highlighted in red. So mechanical valve, systemic right ventricle, Fontan circulation, moderate left ventricular impairment, that's an EF of less than or equal to 45, but greater than 30. And then severe left ventricular impairment is EF of less than 30%. Cyanotic heart disease, unrepaired, other complex congenital heart disease, aortopathies like Marfan's and Loeys-Dietz, pulmonary artery hypertension, severe systemic ventricular dysfunction, previous peripartum cardiomyopathy without residual impairment is class 3, and then class 4 is a previous peripartum cardiomyopathy with any residual impairment. Moderate mitral or aortic stenosis is class 3, but then severe symptomatic mitral or aortic stenosis is class 4. Marfan's with a dilated aorta greater than 45 millimeters, class 4, and then aortic dilation greater than 50 with a bicuspid aortic valve is also class 4. And then native severe coarctation is class 4. You can scan that QR code there to access one of the charts with these conditions. And then we're just going to briefly talk about severe maternal cardiac conditions, all these conditions we just talked about, and just give you some quick tips to be able to assess these patients if they present to you in pregnancy or early postpartum. So just some quick things that you need to think about. If you have a patient, an initial prenatal visit with a patient with a known WHO class 3 or 4 condition, you should consider a cardiology consult immediately or within 1 week. So really important that if you see this person in early pregnancy, that you consider an immediate cardiology consultation or within 1 week, because these patients can get into trouble very early in pregnancy in some of these conditions. And you also want to give some of them an option to terminate if they so choose to. We're going to start with cardiomyopathy and heart failure. This is the most common severe maternal cardiac conditions. Understand that most of the patients that present to you will not have a known history of cardiomyopathy. And so we'll talk about that a little bit later, but you will have some patients with a known history of heart failure or cardiomyopathy that present. And so again, may not have a history, usually occurs though postpartum. So when you have peripartum cardiomyopathy, it usually is going to happen in the postpartum period. They are really sensitive to fluids and have to be cognizant of and looking for fluid overload. And remember, pregnancy is contraindicated if you have a patient with known heart failure with an EF of less than 30% or with previous peripartum cardiomyopathy and residual impairment. So if they had previous peripartum cardiomyopathy and then now they have any residual impairment, pregnancy is actually contraindicated because of such the high risk of a maternal cardiac event or maternal mortality. So next, myocardial infarction and coronary artery disease in pregnancy. So there are 2 basic types. There is pregnancy-associated myocardial infarction, or PAMI, and then spontaneous coronary artery dissection, which we refer to as SCAD. And so these 2 can occur in pregnancy and postpartum. These patients oftentimes have no history of coronary artery disease, but typically they will present with tearing, ripping chest pain. So these patients will present in an acute setting with chest pain, and you have to have a heightened sense to remember to order a troponin so that you don't miss a patient with SCAD or PAMI, and remember to order that in those patients. Risk factors include hypertension, diabetes, smoking, thrombophilias, advanced maternal age, multiparity, IVF, Marfan's, and Ehlers-Danlos. So really just remembering those key findings of that tearing, ripping chest pain, those patients really need a troponin to assess the potential for PAMI or SCAD. Pulmonary artery hypertension carries a high mortality rate. And these patients, again, pregnancy is contraindicated, it's class 4. These patients are fluid and rate sensitive and have to be managed in a tertiary care center. So during pregnancy, if they remain pregnant, they definitely should be watched at a tertiary care center that specifically cares for women with pulmonary artery hypertension in pregnancy. There are multiple things that need to be done to optimize them during pregnancy so that they potentially don't have an event during pregnancy. And if they make it through pregnancy and deliver, the time you really want to be cautious is during postpartum days 2 to 3. This is when all the fluid shifts from the previous placental circulation will dump back into the maternal system and put these patients at extreme risk for fluid overload and potentially throwing them into an arrhythmia. And if these patients are thrown into an arrhythmia or have a cardiac event, many of them cannot be resuscitated, which is why the mortality is so high. Aortopathies. So these are patients with Marfan's, Ehlers-Danlos, bicuspid aortic valve, Turner's, Loeys-Dietz, familiar thoracic. If you have a patient with an aortic root of greater than or equal to 4 centimeters, really you have to beware and be on heightened alert that these patients are at risk of rupture. And you really want to be careful because there may be an indication for them to either terminate or to have a repair during pregnancy. Pregnancy is contraindicated if in certain conditions, depending if it's 4.5 or 5 centimeters. And so it's really important to get an echo early on and have that measurement and know that measurement. And again, if these patients become hypertensive or have tachycardia, they potentially can have a rupture at that point. So really managing their blood pressure, keeping them normotensive, and keeping their heart rate normal is of utmost importance. But you can understand in a patient that's pregnant or postpartum, we know things happen like preeclampsia, and you can't predict those things. And something like an aortopathy, an aortic root dilation, can end catastrophically if these patients are not managed. And so that's why it's really important to know ahead of time so that you can get these patients repaired. And that's the problem is with these patients, there's no warning sign. So if they have the dilated aorta and they get into a situation where they have hypertension or tachycardia, their outcome can be catastrophic because you get no warning signs. Once they present, once they rupture, imminent death for many of these patients will occur. Valvular disorders, this is one where people tend to kind of not be as cautious, but aortic and mitral stenosis are really severe conditions. And many of these patients may have had a repair, but these valves can expire. So it's really important to know when the patients had their repair and how long the valves tend to last. It's also important to get with their cardiologist to know if they are having symptoms, because if they're not, pregnancy will definitely cause them to be in an induced state and potentially have symptoms at that time. They're very fluid and rate sensitive, so you have to be extremely careful giving these patients IV fluids for routine things. And they can get into trouble very early in pregnancy. For those who don't remember, your fluid volume and total blood volume increases starting in the late first trimester, early second trimester. And so you can see patients with difficulty managing these fluids with aortic stenosis or mitral stenosis in, like I said, 13 weeks, 14 weeks. You can see these patients get into trouble at that time. And if on top of that, they come into the hospital for any reason and get some additional fluids, these patients can have catastrophic outcomes as well. And so that's why pregnancy is contraindicated in severe cases because of that. And then congenital heart disease and arrhythmias, I'm not going to go into a lot of that because they're so vast, but you really, if you have a patient with a history of a congenital heart disease, you need to identify the abnormality if you can, and then get them to see cardiology and kind of pin down what that was, if it was repaired, and the status. And then you really want to find out, like I said, even if it's repaired, they can also still get into trouble, especially if it was repaired as a child. And then arrhythmias can be problematic in labor and anesthesia with being able to mount responses that you need in stressful situations. So important to know these conditions and not gloss over them. Again, really trying to dig into that history to find out what it is exactly that you need and what kinds of things will get patients into trouble. Ultimately, you need to remember that all these conditions can potentially lead to heart failure, which is how these patients end up dying, right? So really think about these severe maternal cardiac conditions, think about what can worsen them and what can get these patients into trouble. Again, think about for those patients that are WHO class 4 patients, offering them elective termination or recommending that for them, even if they need to seek those services out in another state. But really understanding that the path leads to heart failure for many of them if they get into trouble. And so this is a resource that we created. It's the Cardio OB Acute Care Guide. This is a trifold version. You can scan the QR code there. It was developed as a tool to be used by OBs and other emergency providers that manage pregnant patients in acute settings. So in emergency rooms, family medicine, midwives, OBs, triages. So this is meant to help you with patients with the previous WHO class 3 and class 4 conditions, that if this patient presents with known, say, aortic stenosis or known Marfan's and shows up pregnant in your ER, in your urgent care, in your office, these are the things that help you to understand how to acutely manage them and get them triaged to the tertiary care center, and hopefully not worsen their condition. And this is the same information available as digitally online. We also have it available in a poster form that you can post in your office where you're charting. And this is the same information in an app form. So you can scan the QR code and add the app to your phone. If a patient presents to you acutely with one of these conditions, you can look it up to help you kind of navigate what to do in the acute setting. So why are we missing the mark in improving mortality related to cardiovascular disease? Why? So for many people, we are delaying their response time, and we have an inadequate response to signs and symptoms. Also, many times we have ineffective or inappropriate treatments. Misdiagnosis is the case for a lot of patients, and then again, failure to refer or consult. So that's really important that we highlight very early that these patients, if they have known conditions, we need to identify those conditions and get them referred to the cardiologist or get a consultation in-house. Another thing I want to highlight too is preeclampsia and cardiovascular disease are intimately linked. And so we know now that a history of preeclampsia is an early indicator of future cardiovascular disease in women. You get double the risk of developing a heart attack or stroke if you've had preeclampsia in the past. If you have preeclampsia or severe preeclampsia diagnosed before 34 weeks, you have 4 times the risk of developing cardiovascular disease over your lifetime. So you can understand if a woman had preeclampsia, in her first pregnancy, and then she now presents at 41 or advanced maternal age, she now has an increased risk of developing cardiovascular disease. So when that stress test happens, that pregnancy time or postpartum period, she's at elevated risk. So much so that in 2011, the American Heart Association added preeclampsia, gestational diabetes, and elevated blood pressure in pregnancy as risk factors for developing heart disease. So while it's important that we know that WHO class 3 and 4 patients are at the highest risk of having a cardiovascular event during pregnancy and postpartum, the majority of your patients that present with a cardiovascular event during pregnancy or postpartum have no history of cardiovascular disease. So I can't stress that enough. So while the patients we just talked about are at highest risk, right? We know those patients have a really high risk of having a maternal event or potentially of even dying during pregnancy. That's not the bulk of our patients. Most of the patients that you see that present with a cardiac event during this period will have no history whatsoever. So we need to address those patients as well. That's why cardiovascular screening in pregnancy and postpartum is so important. And it really focuses on identifying patients with heart failure and myocardial infarction, specifically because this is where the majority of patients with no history will present with heart failure, cardiomyopathy, or myocardial infarction. So what's the most common presentation of heart failure during pregnancy or postpartum? Dyspnea, shortness of breath, palpitations, chest pain, swelling of the legs and feet. The answer to that is dyspnea or shortness of breath. And I know for many of us, we kind of just gloss over like, oh, you're just short of breath, you're pregnant. That happens in pregnancy because elevation of your diaphragm and the pregnancy and growing uterus and all the things. But again, dyspnea, shortness of breath is something that we shouldn't take lightly, and ensure that we are addressing any new onset symptoms. Pre-existing cardiovascular disease and or new onset peripartum cardiomyopathy may initially present during pregnancy or in the postpartum period. So that may be the first time you see a patient present with it. Physiologic changes associated with pregnancy gradually return to baseline by 2 weeks postpartum. But peripartum cardiomyopathy frequently presents in the first postpartum week, with 75% of patients with peripartum cardiomyopathy presenting in the first month. Pregnant women or postpartum women with cardiovascular disease frequently present with shortness of breath or a new onset cough. So really important that we, again, pay attention to that as a symptom and don't overlook it, especially in the postpartum period. When a woman presents in the postpartum period with complaints of shortness of breath, you should also ask if she's experienced worsened level of exercise tolerance. Does she have difficulty, doing routine things? So taking the clothes to the washer and dryer, walking upstairs, symptoms that are getting worse, because essentially they should be getting better, right? Of course, chest pain, palpitations, dizziness, new onset cough or wheezing, lower extremity edema, if it's getting better, if it's getting worse, unexpected fatigue, needing to stop frequently when walking, inability to lie flat due to shortness of breath, how many pillows are they using at night, failure to lose weight or unusual weight gain, especially after delivery. These patients should be losing weight, not gaining weight. Of course, a history of cardiac or pulmonary conditions, a history of substance abuse or tobacco use. And here's a big one. Many patients that present in the postpartum period with a cardiovascular event have been seen by other providers or in other emergency departments since giving birth. So I don't want to gloss over this. Many of the patients that we know who unfortunately died during pregnancy or postpartum had visited multiple ERs or urgent cares before they ultimately died. And so really important that if a mom is coming in and she's recently delivered or was recently pregnant, you really should be asking yourself, what is going on with this patient, and have a heightened sense that this patient could be suffering from a cardiac event. So this is where we're going to get into cardiovascular screening. And this algorithm was validated. It was applied to deaths in California between 2002 and 2006. And what they found is when they applied this algorithm, 88% of the cases would have been identified if they had been screened using the screening tool. And so this is where Dr. Hamid and the CMQCC, the California Maternal Quality Care Collaborative, came up with this algorithm. And then they also realized that the detection increased to 93% when it was restricted to cases that were symptomatic. So really in the patients that were symptomatic, you can see how adding on this screening tool was great. But even in the cases that the patients weren't symptomatic, screening the women in this period could have led to 88% of their deaths being prevented. Now we're going to talk about the who, the when, and the how, right? So this is the most recent ACOG practice bulletin that focuses on cardiovascular disease and heart disease in pregnancy. And it highlights the what I call the CMQCC two-step screening algorithm, which is in the diagram there. But ACOG recommends that all women should undergo cardiovascular disease assessment in the antepartum and postpartum periods using the California Improving Healthcare Response to Cardiovascular Disease in Pregnancy and Postpartum Toolkit algorithm. So they actually recommend that all women be screened during the antepartum and postpartum periods using the CMQCC screening tool. And so I want to highlight here that there are two versions of the same screening tool. So there is the California screening tool, which is on the left, which was developed first. And I call it the CMQCC two-step because there are two steps to it. One that we've labeled the maternal cardiac warning. The other we've labeled the maternal cardiac watch. And then there is an American College of Emergency Physicians endorsed version as well that's endorsed by ACOG as well. But really, it is the same screening tool that has been basically combined into one basic step. And it also includes a troponin and a chest x-ray in the first step, really so that emergency providers are not missing PAMI or SCAD. So they don't miss pregnancy-associated myocardial infarction or spontaneous coronary artery dissection. But essentially, they're versions of the same thing, again, with the ACP-endorsed version, including troponin and chest x-rays in the first step so that we don't miss those patients acutely presenting with PAMI or SCAD. So this is the CMQCC screening tool in detail. So this is what we call or coin the maternal cardiac warning. So this is the patients with red flags, right? So shortness of breath at rest, severe 4-pillar orthopnea or greater, resting heart rate of 120 or greater, systolic blood pressure of 160 or greater, respiratory rate of 30 or greater, and then O2 saturations of 94% or less, with or without a personal history of cardiovascular disease. These patients should immediately be evaluated in triage or the ED, immediately evaluated and or hospitalized for acute symptoms. And they should also get immediate evaluation by cardiology or primary care, depending on where you are, and maternal fetal medicine. And then on the sidebar, if you have a patient with a history of cardiovascular disease without red flags, so maybe they're one of those class 3 or WHO class 3 or 4 conditions, and they don't have any of these red flag symptoms, you still should obtain consultations with MFM and cardiology. And the timing, you probably need to decide, but very likely these patients need to be seen, if not that day, probably within 1 week if they don't have any red flags, because again, you don't quite know when those patients will get into trouble. And so this is step 2. So if your patients do not have any of these red flag symptoms, then you would go to step 2 to see if the patients qualify for screening. I mean, qualify for any further evaluation if they fall into any of these categories. So if they have no red flags and no personal history of cardiovascular disease and are hemodynamically stable, then those patients you should evaluate for symptoms, vital signs, and risk factors. And basically, if they have at least one symptom, one vital sign, one risk factor. So if they have at least one in each category, then they should go to the next step and get further evaluation. Or if they have any combination of those, so maybe they have 2 symptoms and 2 vital signs, then those patients, if they have any combination adding to 4 or greater, they should also go to the next step. Off to the side are physical exam findings. So if the patient also potentially has a loud murmur or bibasilar crackles, so these patients will have more symptoms. Those 2 symptoms or findings indicate that there could be a cardiovascular event. They should definitely be evaluated immediately as well. So they go directly to that next step. This is the American College of Emergency Physician endorsed version of the same screening tool. What you should know about this one is the basic premise behind this is being sure that these emergency providers evaluate the patient and ask them, are you pregnant or have you been pregnant in the last 12 months? Because we identified that many of these patients may not be telling their providers that they have been pregnant, and so those providers are not aware. And if we get providers to really understand that this time period is the most important because of their risk of cardiovascular disease, then potentially they'll know to screen these patients and intervene. And so again, same basic red flags. They just combine them. And so again, severe orthopnea, shortness of breath at rest, chest pain at rest with minimal exertion, palpitations with near syncope, systolic greater than 160 or less than 90 for systolic blood pressure, heart rate 120 or greater, respiratory rate. This one's a little different. So 25 or greater, O2 sat 94% or less, again, and then they include those physical exam findings. So a loud systolic murmur, diastolic murmur, S3 or S4, wheezing or crackles on lung exam, and distended neck veins. So again, they combine those things there. And then they also talk about some other signs or symptoms that may be vague that you need to think about. But if they have these red flags, these patients should go on to the next step. And so if the patient screens positive or at risk on either one of these screening tools, what's the next step, right? Could be the tip of the iceberg. So you want to know, what do we do now? So again, the next step really is to get an EKG and BNP, right? So EKG and B-type natriuretic peptide, right? Those are the things, that's the immediate next step that you want to do for anybody that's at risk or positive. And this is on the ACEP endorsed version. Again, the next step being EKG, BNP, chest X-ray, and troponin. Remember, they added those 2, really highlighting the fact that we don't want to miss patients with pregnancy-associated myocardial infarction and SCAD, spontaneous coronary artery dissection. So that's the next step. So remember, EKG, BNP, those are critical, right? The BNP is really going to allow you to pick up patients that are at risk for heart failure. And of course, the troponin is going to identify the patients with MI or SCAD. And so for those of us that may not be as familiar with BNP or NT-proBNP, a BNP of greater than 50 but less than 100 is suggestive of heart failure. But a BNP of greater than 100 is diagnostic of heart failure generally. And then an NT-proBNP. So some of your institutions may use an NT-proBNP. I know we do primarily at our institution, but a BNP between 450 and 900 is going to be suggestive of heart failure. And then over 900 is going to be diagnostic of heart failure. So if you think about both of these numbers, if you remember 100 and 900 for your NT-proBNP, half that is going to be suggestive of heart failure, right? So if we commit to memory what is diagnostic, then all you have to do is half that to know whether or not you need to be suspicious and still consider an echo and cardiology consult, even if they're in that suggestive heart failure. So that's where you may look for other signs and symptoms to decide whether or not you need to go ahead and order that echo or cardiology consult. But definitely, if you're above 100 for a BNP or NT-proBNP of 900, you're going to order that echo and order that cardiology consult. And again, we're not really focusing on this part, but if they screen at risk or positive, again, the initial first steps are that EKG, BNP, troponin if they also have the complaints of chest pain, and then these other things you can think about, D-dimers, ABGs, depending on your other findings. And then chest x-ray is something that you consider on the imaging side, and then echo, of course, depending on the results of your BNP levels. So we're going to go back to that case that we previously started at the beginning. So 25-year-old obese African-American G2P2 presents to the ED 10 days after an uncomplicated vaginal delivery with fatigue and persistent cough, shortness of breath, dyspnea, and chest pain since delivery. Blood pressure now is 150/98, heart rate's 119, respiratory rate 22, afebrile with an O2 sat of 94% on room air. This patient gets screened using that cardiac screening tool, and an EKG, NT-proBNP, troponin, and chest x-ray are ordered. And so in this case, this patient had a positive CVD risk assessment because the O2 sat was 94% or less, right? And so that patient immediately goes and gets promptly evaluated, doesn't go home, goes straight to triage or goes straight to the ER and gets that EKG, NT-proBNP or BNP, and then depending on that, whether or not you follow that up with an echo. And again, if there was chest pain, you also would order a troponin at that time and potentially chest x-ray. And so again, even using the other screening tool, identifying here that the patient had an O2 saturation of 94% or less, they would have screened positive and then moved on to the next step. EKG is significant for ST elevation, and NT-proBNP was 750. Troponin is markedly elevated, and more cardiac enzymes, coronary angiogram, and echo are ordered. Coronary angiogram is consistent with spontaneous coronary artery dissection, and cardiology is consulted. She's admitted to the CCU and treated for SCAD and remains in the hospital for 2 weeks until discharge home. She's followed by cardiology Q1 to 2 months, and brings her baby to her annual visit to your office when the baby is a year old. And so this is just to show you that employing this screening tool potentially could save lives. Much different than what happened to Dr. Shalon Irving, the case that I presented in the beginning. If we potentially see these patients with symptoms, can we intervene earlier, and should we? So key points: red flag symptoms or signs require immediate evaluation. And if patients are symptomatic but don't have red flags, consider further evaluation if other signs or symptoms are present. These are some of those other signs and symptoms. So again, same case, a little bit different. 25-year-old obese African-American G2P2 presents 10 days after an uncomplicated vaginal delivery, fatigue, persistent cough since delivery, blood pressure 110/80, heart rate 110, respiratory rate 24, afebrile with an O2 sat of 95% on room air, gets diagnosed with presumed new onset asthma and is prescribed a beta agonist. So they thought, okay, we think you have asthma. Here you go. Take this inhaler and go home. 1 week later, she presents again with continued symptoms and complains that the inhaler is not working. The resident applies the CVD screening algorithm and has the following findings: respiratory rate of 28, O2 saturation of 95% on room air, heart rate is 110. She's African American, and asthma unresponsive to therapy, which is one of the symptoms that's there. The patient screens positive for CVD risk, and just showing you here, this patient had any combination that was 4 or more, but actually she also had screen positive by having 1 positive in each category. So she had 1 symptom, 1 vital sign, 1 risk factor. That would move her to the next step, or even just any combination that's 4 or more moves her to the next step, which would be to then go ahead and further evaluate. So again, remember, if they have at least 1 symptom, 1 vital sign, 1 risk factor, they screen positive, or any combination that equals 4 or more, they should go on to the next step. And again, here, using the ACEP endorsed version, you look for the red flags. If they have any of these, yes to any one of the red flags, then you move to the next step. And this patient had a respiratory rate that was 25 or greater. So a chest x-ray, EKG, and BNP are ordered. Chest x-ray reveals mild pulmonary edema. EKG is significant for sinus tachycardia, and BNP is 220. So an echo is ordered because the BNP is above 100. Echo shows an EF of 40 to 45%. Cardiology is consulted and she's admitted to the CCU and treated for peripartum cardiomyopathy and remains in the hospital for 8 days until discharge home. She's followed by cardiology with Q3-month echo and brings the baby with her to her annual visit in your office when the baby is a year old. And again, just really highlighting too that these patients can get into trouble, but what a different outcome you can have potentially if you screen these patients early on to identify that the patients actually have cardiomyopathy or heart failure. Another key point here is that new onset asthma in adults is rare. So we shouldn't be looking for patients to develop new onset respiratory diseases in the postpartum period or during pregnancy. And remember too that patients can get better with bronchodilators. Even with CHF, you can improve on, with bronchodilators. If you give somebody an albuterol inhaler, that doesn't necessarily confirm the diagnosis of asthma. So don't always just think, oh, she got better, she's definitely got asthma. CHF can also get better with some bronchodilators, but eventually they're going to get worse. So again, same case, just a little bit different. 25-year-old obese African-American G2P2 presents for a postpartum visit 10 days after an uncomplicated vaginal delivery with fatigue and persistent cough since delivery. Remember that shortness of breath or new onset cough. Blood pressure is 110/80, heart rate 119, respiratory rate 24. She's afebrile with an O2 set of 95% on room air. She gets diagnosed with a respiratory infection and is prescribed an antibiotic. Fatigue is attributed to lack of sleep. 1 week later, she presents to the family medicine office with continued symptoms. The resident does a lung exam and identifies bibasilar crackles on inhalation and remembers the CVD screening algorithm. Patient is sent to the ED where an EKG, echo, and BMP and cardiology consult are ordered. Remember, those are those severe symptoms. The patient's labs and studies are consistent with cardiomyopathy. Patient is admitted and managed by cardiology, and the patient is discharged home after a 2-week hospital course. And so again, this is highlighting here that the physical exam findings, these abnormal findings, allowed heart murmur or bibasilar crackles automatically move you to the next step, right? So these patients should get evaluated fairly quickly. So if you hear a loud murmur or bibasilar crackles, go ahead, consult MFM and cardiology because CVD is highly suspected. And just a reminder, again, for those of us that are not cardiologists, of course, we all kind of can know what our bibasilar crackles are, but a loud murmur, remember, is going to be a grade 5, audible with the stethoscope lightly touching the chest. And then, of course, bibasilar crackles can be associated with heart failure. Yes, it can be associated with pneumonia, but heart failure is definitely something you want to be paying attention to in pulmonary edema. And so that's why those patients should immediately get evaluated by having those exam findings alone. So key points: symptoms related to physiologic changes of pregnancy should be improving in the postpartum period. Visits to the emergency department or urgent care for dyspnea should raise suspicion for your cardiovascular disease. And again, lung or heart exam findings are most likely associated with CHF, so those bibasilar crackles. And then postpartum dyspnea or new onset cough should always be concerning for cardiovascular disease. Again, pneumonia in immunocompetent adults is rare. So again, while patients can develop pneumonia, still be very suspicious of cardiovascular disease in pregnancy when patients present with shortness of breath. And if a patient's presentation is inconsistent with infection, so she doesn't have a white count, she doesn't have a fever, really you should be thinking, why am I talking myself out of this patient to have a cardiac event? If it warrants a further workup, go ahead and order that EKG and BMP. I will tell you, you'll never be upset with yourself that you ordered it. And so now we're going to talk about the how. So how do we implement these things? How do we screen patients? So we have converted the screening tools in some kind of easy to use things. So we have some maternal cardiac watch and warning posters that we created that you can post in areas where pregnant and postpartum patients are evaluated. We also converted them to badge buddies, so you can put it on your badge and be able to use that very quickly to look and see if your patient needs to have a further workup or consultation with MFM or cardiology. And coming soon to an ED near you, you hopefully likely will have cardiovascular risk assessment in your EHR. And I know some institutions like Northeast Georgia are already doing this. We are working on implementing it in our EPIC as well, but it hasn't quite happened yet. But this will likely be coming to a lot of your institutions soon. So now I just want to run through a quick couple of practice cases to help you kind of remember what we talked about here today and really just highlight the things that we talked about to ensure that you understand that all these patients, pregnant or postpartum, up to a year postpartum, should be screened, and just kind of little tidbits of information to make sure that you hold on to these things and keep them in the back of your mind in case a patient presents with these things. So we have a 43-year-old African-American G1P1, 6 weeks postpartum with complaint of congestion, shortness of breath, sore throat, subjective fevers, and chills. Blood pressure is 149/88. Heart rate is 130 and temperature is 101.3. So she's febrile. What is the best next step? Is it obtain an upper respiratory panel, EKG, and BNP? Order a preeclampsia panel, or order an albuterol, levobuterol breathing treatment? So what should we do? A breathing treatment, preeclampsia panel, or get an upper respiratory panel, EKG, and BNP? So the answer is go ahead and get an upper respiratory panel, right? She is febrile to 101.3, but because the patient has red flag symptoms, she's got a heart rate that's 130, right? And she's 6 weeks postpartum. She's 43. These are all the things kind of still helping you to understand. And she's got shortness of breath. This is not the patient you want to miss, right? So while she can be presenting with something like the flu or, pneumonia or something like that, right? While she could be or COVID, she could also be presenting simultaneously with a cardiac event, right? So you don't want to miss that. So if all you have to additionally do is order the EKG and BNP, go ahead and do that if it's going to help you identify somebody with heart failure. So again, we have a 34-year-old G3P2012 who's postpartum day 6 after a spontaneous vaginal delivery with chest pain and shortness of breath. Vital signs 156/93, heart rate is 125, temperature is 99, O2 sat 96% on room air. What is the best next step? Is it a preeclampsia panel? Give a dose of IV Lasix, order a BNP, troponin, EKG, and chest X-ray, or order a CTA D-dimer. So in this patient, she's again 6 days postpartum, but she's got chest pain and shortness of breath. And so this patient, again, should get a BNP, troponin added now because of the chest pain, right? EKG and chest X-ray, right? So this patient screens positive because this patient has chest pain and shortness of breath, and then a heart rate of 125, which puts her in that red flag category, right? So because of the red flags, go ahead and order the BNP, troponin, EKG, and chest X-ray. And remember, the troponin comes into play here because of the chest pain, and you don't want to miss PAMI or SCAD. So 32-year-old G1P0 at 38 weeks. So this patient's still pregnant with a history of asthma and presents to the OBED with cold-like symptoms for the past 3 days. She also reports worsening shortness of breath and wheezing, not relieved with her albuterol inhaler. She's afebrile and vital signs are stable. What is the best next step? So this patient is pregnant, known history of asthma, comes to the OBED, sounds like she's got a cold, and is more short of breath and is wheezing. So is it EKG, BNP, and chest X-ray, pulmonology referral, CTA D-dimer, or order a breathing treatment, right? So in this patient, because of her history, and she doesn't have any severe symptoms, remember her vital signs are stable, just order a breathing treatment. So again, we're not trying to get you to do labs and EKG, BNP, and chest X-ray on everyone, right? This patient does have a history of asthma. Sounds like she got a cold, and that could definitely exacerbate her asthma. And she might just need a breathing treatment. So you should start there in this patient. But remembering, she's afebrile, her vital signs are stable, and she doesn't have any red flag symptoms. So you would go ahead and start with what you normally do and give her a breathing treatment. 32-year-old G1P1, past medical history of asthma, presents now 3 weeks after vaginal delivery. So this could be the same patient, right? So she came in before when she was 38 weeks and had a little cold and got a breathing treatment. Now she's delivered And 3 weeks after her delivery, she has worsening shortness of breath and wheezing that's not relieved by her albuterol inhaler. And this patient was also seen in urgent care last week with similar complaints and states that the breathing treatment you prescribed and the inhaler are not working. Vital signs 118/70, heart rate 119, respiratory rate 24, temperature 98, so afebrile, O2 sat 96%. What is the best next step? And I think the key here is that this person was seen recently and the treatments that you prescribed are not working, right? So this patient should at this point get the EKG, BNP, chest x-ray, right? So this patient was getting better before and was, if you gave her breathing treatments or otherwise getting better. But remember, one of those red flag symptoms was asthma that is refractory to treatment, right? So unrelieved by your current treatment. Those patients should get a workup. And remember, heightened sense of awareness because this patient is in the prime time for having a cardiac event postpartum. All right, a 25-year-old G2P1 at 12 weeks gestation, so this patient is pregnant with a history of a congenital heart defect, presents to the OB office for a prenatal visit. Vital signs are a blood pressure of 130/80, resting heart rate of 122. Patient is otherwise asymptomatic. What is the best next step? Is it a cardiology and/or MFM consultation, baseline echo, IV fluids and pain medication, or order an EKG and BNP? So it looks like they're here just in the OB office for a prenatal visit and have a little bit mild elevated blood pressure, but a heart rate of 122. And so this patient should get an EKG and BNP. So even though they're not complaining of anything, the heart rate of 122, especially in the setting of a congenital heart defect, this patient should go ahead and get an EKG and BNP. And depending on that, you may still go ahead and get the cardiology and MFM consultation, but definitely start with this EKG and BNP because although she's 12 weeks, you don't know what this congenital heart defect is, whether it's repaired or what. This is her second pregnancy, but very well could still be symptomatic from that. And you don't want to miss a patient that potentially is presenting with a cardiac event. All right, a 35-year-old G4P2012 with a history of Marfan's disease presents to the OB office at 6 weeks for an initial prenatal visit. Vital signs are stable, and she is currently asymptomatic. After completing her first visit in prenatal labs, what is the best next step? Is it an outpatient referral to cardiology with visit in 1 to 2 months? Consult OB MFM immediately for possible hospital observation and baseline echo? Is it EKG, BNP, troponin, and chest x-ray? Or do you refer the patient to Planned Parenthood or Feminist for termination of pregnancy? And so this patient, again, 6 weeks pregnant, Marfan's disease, and currently asymptomatic and vital signs are stable. So what's the next best step? This patient actually should get an MFM OB consultation for baseline echo. And remember, the reason is with Marfan's disease, you're concerned about aortic dilation or aortic root dilation or aortic dilation. And so these patients, you really need to have what their baseline status is on their aorta, what the baseline measurement is, because you very well may not get a warning sign in the event that this patient ruptures. And so you're going to want to know that now, because depending on what it is, pregnancy may already be contraindicated and you might need to refer this patient for a termination. But also, depending on where it is, if she chooses even to keep the pregnancy and didn't want to terminate, the patient may warrant repair early in pregnancy. Okay, so because of such a high risk of a rupture. So you really need to know what her status is, so that what the status of her aorta is now. So you need that baseline echo. All right, a 30-year-old African-American female at 18 weeks with a history of peripartum cardiomyopathy presents to the ED for an ankle sprain. While taking her history, you notice that she stops to breathe in the middle of sentences. She's normal tensive and her urine is negative for protein, glucose, and ketone. What's the best next step? Is it an outpatient referral to perinatal cardiology? Is it order an EKG, BNP, and chest x-ray? Is it order an echo? Or is it to give the patient a prescription for Lasix and reassure her and follow up at the next routine prenatal visit? So again, reminding you, this patient is currently 18 weeks, but history of peripartum cardiomyopathy, and she's short of breath at rest because she's stopping to breathe in the middle of sentences. So she's got a red flag symptom. This patient should definitely get an EKG, BNP, and chest X-ray. Okay, so even though, you don't know where this patient is, she's already had a history of peripartum cardiomyopathy. So her heart very likely is not normal already. And we don't know if she's got any residual disease or any residual impairment of her left ventricular output. So you need to really get that EKG, BNP, and chest X-ray. You don't need to go directly to the echo, but you very likely may end up getting one. But you should definitely start with the EKG, BNP, and chest X-ray in this patient. 35-year-old African-American G3P2 at 12 weeks gestation presents for a cough and shortness of breath with a history of aortic stenosis, status post-biologic heart valve replacement 15 years ago. She's normotensive. Her resting heart rate is 115. Temperature is 101.3. O2 set is 95%. Respiratory panel is positive for influenza. What is the best next step? Is it start IV fluids and begin Tamiflu? Is it give a patient a prescription for Tamiflu and have the patient schedule close follow-up with a visit in 7 days with MFM and cardiology? Is it order an EKG, BNP, chest X-ray, and echo? Or is it supportive care and an outpatient referral to cardiothoracic surgery to discuss valve replacement? So again, this patient is 12 weeks currently, cough and shortness of breath, but a history of aortic stenosis with a valve replaced 15 years ago, and got a little elevated heart rate, but has the flu. So, we know we need to treat her for the flu. So the answer is going to be EKG, BNP, chest X-ray, and echo. And while A might have been the answer that you felt you should start, you have to be very careful. So yes, the patient should be started likely on Tamiflu if she qualifies for having symptoms in the last 3 days or 72 hours. But the starting fluids part is what is very tricky in this patient. Patients with aortic stenosis and mitral stenosis are very fluid sensitive. And if you start IV fluids on this patient in this setting, who's already got fluid overload because she's 12 weeks gestation and her total blood volume has already started to increase significantly in the late first trimester, early second trimester, you could very well push this patient over into fluid overload and into an arrhythmia, which she can't come out of, and essentially end up having a cardiac event from which she couldn't be resuscitated. So you be very cautious of starting patients with stenotic lesions on IV fluids without knowing where these patients are starting. So I would definitely start with this patient, EKG, BNP, chest X-ray, again, an echo probably regardless, because I know this patient already has aortic stenosis and she's had a valve replaced. And so with these symptoms already and a heart rate that's already starting to elevate, I would start with the EKG and BNP chest X-ray, but then the echo you can add on just because of this patient's history already. But again, what's problematic about A is starting the IV fluids. You can actually worsen a patient's condition by starting IV fluids in a patient with aortic stenosis. And so you have to be extremely careful with starting IV fluids in these patients. 26-year-old morbidly obese G1P1 with a history of chronic hypertension with superimposed preeclampsia at 30 weeks. Presents for well woman exam 6 months after a vaginal delivery. So she's 6 months after her delivery. And she has a blood pressure of 145/92, a pulse of 117. She complains that she can't lie flat for her PAP because she's short of breath. What is the best next step? Is it A, an outpatient referral to internal medicine with a visit in 1 to 2 months? Is it to reassure the patient that she's okay, it'll be okay, no problem? Is it an EKG and BNP? Or should we have the patient return for her well woman exam when she's pre-medicated with some Ativan or something so she can relax? And so again, what you have to think about again is this patient is still in that 1 year postpartum period. And remember, she's got risk factors for cardiovascular disease, right? She had chronic hypertension with superimposed preeclampsia. And we talked about having preeclampsia at severe preeclampsia at less than 34 weeks puts her at risk for cardiovascular disease. And while she is young, you can't ignore it. And being short of breath at this point when she lies down, this patient is short of breath at rest and has some form of orthopnea. I would definitely recommend that this patient then get an EKG and BNP, because you want to be sure that this patient's not presenting with heart failure even later. And I can tell you that this has been the case for some of those patients that present later, that people forget that this patient recently delivered in the last year. And even though it's 6 months ago, really are not paying attention to the fact that this patient is short of breath, and they attribute it to anxiety or whatever the case may be and overlook it. And this patient definitely could end up, having an event at home, or, showing up to the ER when it's too late. And so you really want to just remember, order the EKG, order the BNP. You'll never be upset that you ordered it if you end up being right or wrong. All right, and with that, we've come to the end of the presentation. You can scan the QR code here to access any of the patient or provider materials that we have, like those acute care guides, like those maternal cardiac watch and warning to use it for screening tools, badge buddies, all those things. We also have patient materials. So we have peach cards that teach patients the warning signs. We also have Check My Heart emergency cards. And so these are cards that give the patients the language if they have had a baby, if they're pregnant or had a baby in the past year, and they think they could be having a cardiac event. They may come in and ask you to order these things: EKG, chest x-ray, BNP, and troponin, right? So we wanted to give patients the language for this. So patients may also request evaluation. These cards are also available for you to order on the website as well at GapQC. And then again, this is that Cardio OB Quick Reference Guide. And this, you can scan the QR code here to get the app. Again, these are the patients with those pre-existing WHO class 3 and 4 conditions. So if you have a patient with those that presents acutely, how to manage those patients, but then the screening tool for everyone else. And so with that, I just want to say thank you for your participation. Hopefully you can employ this cardiac screening in your offices and in your urgent cares and ERs. And just remember to screen all patients pregnant and postpartum up to 1 year. Thank you very much.